ALL Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the ALL Hub podcast. Today we'll be hearing from Rachel Rau of the Texas Children's Hospital in Houston, US.
Hi, I'm Rachel Rau. Today I was asked to speak about the utility of minimal residual disease, or MRD, in ALL therapy. And I think, we've spent several decades refining our risk stratification for patients with B-ALL, both on the pediatric side and on the adult side. And I think of the prognostic factors we've identified, minimal residual disease is arguably the most powerful. Now, just to start with the technical details, in general, MRD is measured predominantly by two major modalities. Here in the US, we predominantly rely on multi-parameter flow cytometry to distinguish the immunophenotypic blast that a patient is diagnosed with and track the presence of those immunophenotypic blasts over the course of the patient's therapy. In Europe, they tend to use more a PCR-based strategy where they can track the recombined immunoglobulin heavy chain that are characteristic of a patient's leukemic blast. By either modality, these methods are able to detect down to 10 to the minus 4 leukemic blasts, so quite sensitive assays in terms of monitoring a patient's disease response based on MRD. On the pediatric side, we measure MRD over a number of different time points. For some of our patients, we know that a very early MRD response, including as early as day 8 of their therapy, measuring MRD from the peripheral blood can be prognostic. The most powerful prognostic time point for us, however, is looking at the bone marrow MRD at the end of induction therapy, which on Children's Oncology COG studies is 1 month in duration. You'll see slight variations depending on the exact induction protocol being used for a patient. But in general, the bone marrow MRD at the end of that induction course of chemotherapy is likely the most powerful one. For most patients, provided they've achieved an MRD of less than 0.01%, the outcomes tend to be more favorable. And the higher that MRD value is at the end of induction is linked, particularly in B-ALL, with inferior outcomes. So this is one way in which we can identify patients who require an intensification of their post-induction chemotherapy. For patients who have MRDs that's still detectable at the end of induction, we then want to look again at the end of the next block of therapy for us called consolidation. If there's still persistent MRD present at that time, we know for a subset of our patients, namely those who we consider NCI high risk, so kids who are either older than the age of 10 at the time of diagnosis or present with a white cell count of 50,000 or greater. We know that those patients who are still MRD positive at the end of consolidation have a very terrible event-free survival somewhere in the 40% range. And thus these patients were still grappling with how best to manage them. And based on those data, the recommendation had historically been to take them to hematopoietic stem cell transplant as best possibility of achieving a cure. Right now in the Children's Oncology Group, in an industry-sponsored trial with Novartis, we're testing if CD19-directed CAR T-cell can really lead to a significant improvement in those patients' outcomes. And that's our AALL 1721 trial run by Shannon Maud at the Children's Hospital of Philadelphia. Additionally, I think we're also interested in investigating if more sensitive assays to detect MRD below that 0.01 threshold can be used to further risk stratify patients. And now we have the technology to do that with an assay that's available commercially through the company Adaptive in Seattle called the clonoSEQ assay. And the clonoSEQ assay is a DNA-based mode of detection of MRD, using that same idea that in most B-ALL samples, the immunoglobulin loci have recombined at a point before the blasts transform. And so then that recombined immunoglobulin loci can then be used as like a barcode, a DNA barcode to track the leukemic blast over time. And that is sensitive down to 1 in a million or lower. So it's an ultra-sensitive modality for detection of MRD. So in our current Children's Oncology Group trial, AALL 1731, we're taking a subset of patients with an intermediate prognosis who are all flow MRD negative at the end of induction, and seeing if we can further stratify those patients based on this more sensitive DNA-based MRD mode of detection. We have retrospective data suggesting that it can more finely parse those patients into prognostic groups, but we'll prospectively define that through the conduct of AALL 1731. So just in summary, I think MRD has helped sort of revolutionize the way we risk stratify patients. It's helped us identify the subsets of patients who definitely require an intensification of therapy after their induction phase. It's also allowed us to identify a group of patients with an absence of clearance of their MRD within a few phases of therapy who have a really poor prognosis and warrant either stem cell transplant or investigation of other, including immunotherapy options to clear their MRD. And I look forward to sort of seeing where we go in the future with these more sophisticated modes of MRD detection. Thank you.
Thank you for listening to the ALL Hub podcast. We would also like to thank our supporters, Novartis and Amgen.
ALL Hub Podcasts, brought to you by Scientific Education Support.